come in with chest pain and normal coronary arteries, you would think that I'm going from one end of the pendulum, the really sick of the sick, to really healthy people. But I'm going to show you with this case that I'm going to talk about, it's not really the case. So I'm going to talk about a patient who's been my patient for about 24 years. She's 78 years old, a very, very high, a very intelligent lady who went to Harvard Law School at a time when they still didn't even have a ladies' bathroom in the law building. So she had to leave the building to go to the bathroom. And she was a dean of a law school, so she tolerated a lot of stress for a very long time, and she did very well. But she has a history of coronary artery disease. I stented her LV branch back in 1996. She has hypertension, hyperlipidemia, and she has a mildly ectatic aortic root measuring about 4.2 centimeters and mild to moderate AI, hypothyroidism, and depression. Interestingly enough, about 20 years ago, she had iatrogenic hyperthyroidism with a cardiomyopathy. Her EF was about 30, and that resolved when her synthroid dose was corrected. And I mentioned the aortic dilatation because we've been following her every year with an echo just to assess her aortic root. And about 6 months before this all started, her echo showed a normal EF or very mildly reduced. She's married with no children. She and her husband were inseparable. They would come to the office visits together. I've never seen it for a routine visit. So he got a glioblastoma and died. 4 days later, her PCP called me and said that she got so short of breath when he died that she couldn't even go to his funeral. So her EKG showed a new left bundle branch block. An echo showed her ejection fraction was 10% with global hypokinesis. When we saw her, her troponin was 0.01. We did a cardiac cath, and she had mild non-obstructive coronary disease. On her right cath, her cardiac index was 1.6. So again, cardiogenic shock-like. She was seen by our heart failure team. They tried to get an MRI, but she couldn't tolerate the procedure. They started her on standard medical therapy. She was still symptomatic, and they actually sent her home on home Wilmerdone. She was followed by the heart failure team, and her LVEF normalized by about 6 months. So I'm going to talk about Takotsobu Cardiomyopathy. And this is what it is for everybody who doesn't know. It means Japanese octopus pot in Japanese. And when you see a ventricle of the common form of Takotsubo, this is exactly what you see on the right. You get the ballooning of the apex, and the base continues to contract. So it was first described in 1990. I was a fellow at the time. I can't believe this syndrome has not been around, but when I was a resident, that was not even thought of. About 90% are women, usually postmenopausal, and they often have an underlying psychiatric diagnosis of depression. So normally they have a typical ACS picture. Their EKG may show ST elevation, but usually the ST elevation is not as significant as it is with a standard STEMI, and reciprocal changes are unusual. The troponin is usually mildly elevated. The BNP is usually quite elevated because they have dilatation of their ventricle and atrium. And it actually accounts for about 2% of patients who come in with an acute coronary syndrome. It's frequently, but not always, triggered by emotional stress, and about 4% of the time, it's a positive stress. So you win the lottery and you kind of drop dead, or something great happens. And this has been now labeled the happy heart syndrome. So it's not the broken heart syndrome, but the happy heart syndrome. So you heard it first here. But there's a similar presentation that can occur with a lot of other diseases, such as pheochromocytoma, intracranial hemorrhage, and sepsis, and a handful of other things, including hyperthyroidism. So previously, it was felt to be relatively benign, but the in-house mortality approaches 4 to 5%, which is about the same mortality as we see in patients who come in with a STEMI. So this is not a benign process. These patients die. So next to coming in with cardiogenic shock, it's about the highest mortality that we see in cardiology. So the LV dysfunction is out of proportion to the elevation in the biomarkers. the patterns of LV dysfunction can vary, but about 80% of them have that typical apical ballooning. You can have midventricular ballooning, and this is more common in the happy heart syndrome. You can have basal or focal hypokinesis, and the patient that we had, I'm sure, was Takotsubo, and hers was global. The LV function normally will normalize, but mortality remains high even after discharge. So this has become a very interesting topic, and this is a slide showing the number of publications about Takotsubo syndrome since the 90s, and you can see it has just skyrocketed. So what is going on? I had no idea. Normally I would just see a patient and go, that's cool, and then they get better and we leave it alone. But there have been a lot of studies that have looked at lately what is going on, and it does happen to coincide with syndromes of catecholamine excess. So people have studied the levels of circulating catecholamines in these patients, and they're several-fold higher than the catecholamines that you see in the serum of patients who have STEMIs. So it's not just they're in the hospital and their catecholamines are up. And when you look at the coronary sinus norepinephrine levels, they're elevated as well. And there's MIBG scanning, which looks at the sympathetic activity. It has to do with the cyclic AMP in patients who have Takotsubo, and that is high too. So in the myocardium, it's high. Okay, now I'm going to show this, and I guess when I said no disclosures, I really do need to make two disclosures. The first one I'll make here, I am not a neurobiologist. But let's talk about what happens with stress. So with stress, there's a lot of sympathetic activation in the brain, including the hypothalamus in the brain. And what happens is that triggers certainly the adrenal medulla to secrete epinephrine, but it also, the impulses travel down the spine and then go out to the ganglia, like the stellate ganglia, and then those nerve fibers run along the coronary arteries and the kind of neurovascular distribution, and then they branch and branch and branch, and then the neurosynapses are touching the cardiac muscle. So this was a very interesting study of, there's 3 patients, it's small, but they reference it in just about every article, where they looked at the blood flow, the cerebral blood flow in patients who have acute Takotsubo cardiomyopathy and afterwards. And when you see all that red and the blue and the green, that's all increased cerebral blood flow. And it's all in the areas of sympathetic activation, which is fascinating to me. So you've got the nerve, the sympathetic fibers come down into the lower cervical and upper thoracic spine, and like I said, those are the ones that end up at the heart. Now, okay, so this one is just like really confusing. So on the lower left coming up, that's a little nerve fiber, and it's secreting the norepinephrine, and that's touching the muscle. And you get also primarily epinephrine and a little norepinephrine coming from the adrenal gland. This is even worse. There's going to be a quiz on this. So up in the upper left, the red squiggle, that's a beta receptor on a muscle. That's a muscle fiber of the heart. Okay, so the norepinephrine goes there, and it stimulates something called a G protein, which then helps turn the ATP into cyclic AMP, and a couple things happen. Number one, the calcium comes out of the endoplasmic reticulum and into the cell from the outside, and it causes contraction of the muscle. So the beta receptors, triggered by norepinephrine, work through this GS protein, which triggers the whole contraction process, if that makes sense. And we'll come back to why that's important. So how does the left ventricular dysfunction occur? Number one, some people think that there's direct catecholamine toxicity. So when all this contracts, the sarcomeres actually just kind of freeze. They just kind of freeze, they're stuck. And that's called contraction band necrosis. And that's associated with some interstitial inflammatory response. And it's very similar to that which can be seen with a pheochromocytoma, which is a syndrome of chronic severe catecholamine overload. With that, all that contraction going on, the beta stimulation, there could be an oxygen supply-demand mismatch just at the cellular level that's independent of the vascular supply. You can also envision one of the theories to be epicardial vessel spasm because you have a catecholamine surge, although the wall motion tends not to follow vascular distribution. And then microvascular spasm is another possible reason. And some patients have been shown to have endothelial dysfunction, whether that's related to this or they have independently endothelial dysfunction, I'm not sure. But direct catecholamine toxicity, I think, is pretty high on the list of what the problem is. So okay, but why does it balloon, Why does it balloon? So this is very interesting. This is from 1993, where somebody, Japanese, because it's usually Japanese, studied 26 anesthetized dogs. And they either infused noradrenaline or stimulated that parasympathetic ganglion. And what they saw is that the muscle fibers in the apex of the heart shorten more, and they shorten faster. And that makes sense because you think, well, if the heart's squeezing, it's got to come out of the apex first, otherwise it's going to get stuck there, right? So it kind of makes sense physiologically that that's what happens. And there was a greater increase in the tissue cyclic AMP in the apical myocardium. So all that stuff that triggers the sarcomeres to contract, all that is more prominent, more rapid in the apex than it is in the base. And they also found something very interesting. The beta receptor density in the apical myocardium is higher than in the base. So whatever the stimulus, you got more receptors on the heart muscle fibers to respond to that already high catecholamine surge. So they concluded that there's a greater beta receptor density and or increased myocardial responsiveness to the adenylate stimulation in apical myocardium. And that would actually, in part, compensate for the fact that there's less nerves going there because they start at the base and they go to the apex. Okay, here's the question of the day. I know Joe was asking questions. How many cardiac beta receptors are there? How many subtypes? Anybody know? Dr. Kelly, how many? 3. Who says there's 3? Dr. Mannon? Okay, who says there's 2? Who doesn't know and doesn't care? Okay, they don't care. Dr. Kelly gets the $10. There are 3 beta receptors on the heart. I had no idea there were 3 beta receptors. So I'm giving this talk not as a Takotsubo expert. But okay, so beta 1 is 75 to 80% of the myocardium. Beta 2, 15 to 18. Beta 3 is 2 to 3% of the myocardium, the beta receptors. And it actually doesn't stimulate that GS protein to cause contraction. It actually works on something called a GI receptor, which is inhibitory. And it's a shutoff valve. It's a shutoff valve. It causes a negative inotropic effect on the heart. And you can think of it maybe as a protective mechanism against something like this happening. So one, you get this problem with the contraction because you're overloading the ventricle. And number 2, you have the shutoff valve. And in the chronic heart failure literature that I was kind of reading through, beta 1 and beta 2 get downregulated, but beta 3 does not. And so you can have even a 50% percentage of beta 3 receptors in the failing heart, and how that might contribute to the negative inotropic kind of functioning of the left ventricle is a very interesting question. So is it estrogen related? These are postmenopausal females. Well, I guess you could implicate that there's endothelial dysfunction from lack of estrogen, but in point of fact, and I really don't want to say this because I'm female, but animal studies have shown that high levels of estrogen negatively affect the brain's ability to deal with stress. And when they took rats, female rats, and they did ovarectomies on them, which I don't know how they do that either, and they gave it back, it was, the more estrogen they gave, the more difficult it was for the rat to respond to stressful situations. And premenopausal women are much more likely to have mood disorders where stress is a major etiology, such as PTSD or depression. So from a psychological perspective, the estrogen makes it worse. So why would they have these stress-related responses when they're postmenopausal? All right, and here's where I'm going to digress, and I have to also say I am not a psychiatrist. But what would a man do when he saw this? Well, what's the kind of lingo? It's fight or flight, right? So fight or flight. So when a man is subjected to stress, there's a fight or flight response. And some people actually think now, reading through a little bit of psych literature, that there are genes for that on the Y chromosome, which women don't have, right? So what's a woman going to do? What would stress have caused a woman to do in the prehistoric ages? They're not going to fight that lion, right? What's the woman going to do? Find a man? No. I think the woman would have gone to make sure that the children are safe, right? That's how the woman would have had to deal with the stress, right? Right? And so now in the psychiatry literature, there's this really kind of new concept of how women deal with stress, and it's called tend and befriend. So scientists I'm going to read this because I'll say it wrong, who favor this theory believe that women may have evolved an alternative humoral response that even downplays the fight or flight response. So instead, they argue, women have developed stress responses that provide for the nurturance of offspring, the exhibition of behaviors that protect them from harm, which is tending, and befriending or creating or joining social groups. So there are hormones such as oxytocin, and there's a lot of that being written in the psychiatric literature. There's a surge in that when women are subjected to stress, and it actually kind of pushes them toward that tend or befriend response, and that level falls in menopause. So back to the case study. This patient had a long-term high-stress job and a successful career. She had an underlying depressive disorder, suggesting some kind of a CNS imbalance or abnormality with dealing with stress to begin with. She had a previous cardiomyopathy due to iatrogenic hyperthyroidism, kind of possibly suggesting that maybe she has an increased myocardial sensitivity to catecholamines. And the loss of her soulmate and lack of a close family, because they had no kids and she's from the Northeast, for social support, so there's nobody to tend to, and the loss of her main person who she could befriend. And so there's this loss of a coping mechanism and a triggering of this unopposed stress response that then can cause this catecholamine surge and result in this catecholamine-induced cardiotoxicity. So what next? So I think we still have to understand that Takotsobu Cardiomyopathy is not a benign condition. It has a high mortality even after discharge. More investigation into the pathophysiology of the myocardial injury in response to catecholamine excess and or increased sensitivity to catecholamines is needed. And number 3, I think more investigation into the female response to stress and how it's affected by menopause will be a key factor in understanding the pathophysiology of this syndrome. That's it. Thank you.